So I was just saying it's free inspiration all morning, and I'm sure the rest of the day is going to be like this. Talking about convergence with a lot of minds over here, I have a story for myself. I come from a family, I was the only child. My mother was a doctor, and my dad was an engineer. And I was good in both maths and biology. And I had to choose which way to go, and I chose engineering because I spent a lot of time going to the factory that my dad was running every weekend, working on the lathe, working on the milling machine. It was fun. So I decided to go the engineering way. And as fate would have it, I was actually in the US studying. My dad was diagnosed with stage 4 pancreatic cancer. And nobody diagnosed it. It was completely asymptomatic. It was something that all of us, my mom, myself, very difficult to digest. And so when I came back, I ran my own company for a couple of years, but then I decided I had to do something for healthcare, which is when I moved to the healthcare field. Been in that field for a long time, so as destiny would have it, I'm an engineer like Chandrasekhar, working on healthcare stuff, but living my life. So the presentation I had today, I wanted to make a shift from what G Healthcare has been talking about for a while. We've been talking a lot about innovation for emerging markets, innovation in products, innovation in technology, how we brought the cost curve down, and while improving efficiencies, workflows, productivity, so on and so forth. So today, my story is going to be a little bit different compared to the product story that we've always been spending time on. And the reason is, 6 months ago, we actually created a new business called Sustainable Healthcare Solutions. That in itself is a big step for a company like G Healthcare, which for the longest time has been focused on tier 1 markets and to a certain extent tier 2. But this one is truly about delivering sustainable care for the world. And in a case in point, this image that you see here is an actual image shot in Indonesia. It's an image of a midwife going with the primary healthcare administrator on a bike to a point of care for a mother who's pregnant, carrying a new ultrasound, portable ultrasound device. It uses an Android OS, completely connectable. It's got workflows that actually help a midwife use ultrasound versus a sonologist having to use an ultrasound. So we heard about task shifting, we heard about people working on top of their license curve. It enables us things. But are we truly scaling it to the need of 140 million babies that are being born in the world every day? The answer is clearly no. So we clearly realized over the last 10 years that we've been working on innovations like this. It's so easy to push the boundary of innovation. And now I can stand as an engineer in front of you and tell you, if you give me a technical problem, I will solve it. It's a question of time, it's a question of investment, but we will solve it. The more important question is, how do you get this innovation into the marketplace and sustain the use in such a way that you drive viable outcome? That is a very big question that needs to be answered. So what I'm going to do today is just walk you through the assumptions for sustainable healthcare. This is not a recipe, by the way. So it's just food for thought. It's for all of us to participate in. This is something that's true and relevant today. 5.8 billion people in the world don't have access to scientific healthcare. They have access to many forms of healthcare, but scientific healthcare, which can actually quantify in terms of clinical outcomes, is very limited. On the other side, if you look at the growth of the population, hardly 30 years from now, you're going to be at a number which is almost going to be double of where we are. That in itself is a huge growth in our supply-demand gap for healthcare. So as it is, 70%, 75% of our population is not covered. Now when you go double the size, it is only going to constrain the system even. Interestingly, you've got the 80-20 paradigm, which is all the money today in healthcare is being spent by 20% of the population. Why? The answer is very simple. I have to remain in business. Somebody has to pay for all the investments that we're making in healthcare. So if I have to develop technology, if I have to build a hospital, if I have to educate doctors, whatever it is, every single component of the overall healthcare ecosystem needs payback. Because healthcare at the end of the day, while it seems social, is not social. Right? So you've got this huge dichotomy that you've got to address. And that graph there is actually a telling graph. You look at emerging markets, you've got 5.8 billion people living, and you've got a $1.2 trillion spent in healthcare. This is all healthcare spend, which is delivery, technology, compensation benefits, everything that's associated with healthcare. You look at the developed markets, it's 1.2 billion people enjoying a $5.1 trillion spend. So the argument there is, are you productive enough in the developed markets? And are you accessible enough in emerging markets? So both markets have problems. Right? It's not that one doesn't. But it's an interesting conundrum to answer. This one, the pyramid of care. When you look at developed markets, or when you look at an evolved healthcare system, the usual pyramid of care is very intuitive to understand. It always starts at the bottom of the pyramid. So you want maximum screening, maximum triage, and maximum risk stratification happening where the majority of the population live. So that only the people with risk get promoted up into secondary care, then get promoted up into tertiary care, and your value chain in terms of skills is also organized that way. So you've got people operating, to borrow Ram's words, operating at the top of their license in tertiary. People operating at the bottom, really doing stuff that is just good enough to diagnose what's wrong, and then promote people upwards. The problem in emerging markets is you've got an inverted system. So you've got choking of the hospitals happening in tertiary because you don't have enough screening, enough triage, enough risk stratification happening at the primary care. You're resource constrained, infrastructure constrained, you're constrained in terms of awareness, education of the patient. So there's a whole bunch of constraints. And adding to all that is the complexity of the fact that we're not investing enough in healthcare in that space, which creates this issue. So if you truly want to move towards sustainability, true sustainability, impartial to whether it's technology, whether it's care delivery, whether it's an ecosystem, all that needs to happen is you need to flip this out. So theoretically, a very simple thing. So when you start looking at the $1.2 trillion spent in emerging markets, and when you look at the trend, so I'll give you an example. Last year alone, in Africa, 54 countries, India and South Asia, 6 countries, and ASEAN, which is 10 countries. So 70 countries, 3 billion people. In that zone alone, we had a total healthcare investment of close to $800 billion. These numbers are huge. And yet, if you ask any healthcare provider, or any technology provider, or anybody in the ecosystem, what is your revenue? It's a decimal error out of that $800 billion. So where is that money going? Where is that money going? Who's seeing the productivity of that money? At the end of the day, when there is that much productivity loss, the one who's supposed to benefit, which is the patient, loses out. And therefore, you don't have sustainability in the system. So our theory and our assumption is as we go into focusing on emerging markets, we need to be working closely with the healthcare ecosystem, be it the government, be it the academia, be it other technology partners, be it healthcare providers, to help invert the pyramid. And that's the fundamental assumption for sustainable healthcare. Coming from GE, I had to give a couple of examples. But I'll tell you, we'll talk about our learnings. I'm not going to talk about how nice the products are. Our biggest learning in the first case, the baby warmers. It's interesting. 2 learnings, a good learning and then an afterthought. If you look at the bassinet of that baby warmer, it's aligned in an east-west direction with a long horizontal axis facing. There's a reason for that. In fact, many people address this in the morning as well, that you can't do a market research and the market research always gives you a right answer that should be designed that way. This comes from immersion. So you've got to feel the pain, the beneficiary feels. So if you've got to go feel the pain, a primary healthcare center feels, you feel the pain. In fact, that is oriented that way, and it's possibly the only warmer in the world that's oriented that way. Because the nurse in a primary healthcare center carries the baby this way. It's very easy for her to comfortably place the baby into the bassinet. Versus having to reorient the baby and place it. If you see any other warmer in the world, you can Google it. They all have the axis printed on. And why do they do that? Because in a NICU, in a developed market, you need space. And the only way you can rack and stack as many babies as possible is if you can pack a high density of warmers. In a primary healthcare center, all they have is a light bulb. And they have space. They don't need a vertically inclined warmer. So that was a wonderful learning. But you know what happened? Chandrasekhar was talking about 26,000 PHCs. So ideally, the entitlement is 26,000 warmers that have to get sold in India. We've got 30 million babies, so there's enough warmers to be sold. We hardly scratch the surface. Why is that? Because our competition is not another person who's going to make this former at a lower cost, which has traditionally been the approach. Let's take cost out while making the product better. No. Our competition is actually that like for you to move, and people spoke about it, right? For clinicians and caregivers to move from their existing behaviors into using new technology is a sea change. And the closer we work with them in terms of co-creating a solution and affinitizing them with the solution, the better chance we stand to drive that change. The next example is this, LED, phototherapy. Phototherapy is used to break down bilirubin, used to cure neonatal jaundice. So, my mother is an obstetrician gynecologist. I keep hearing these terminologies a lot. When my daughter was born 12 years ago, in Chennai, this is not tier 3, tier 4 city, I'm talking in Chennai, in a large hospital, my mom had enough connections to give me the best quality of care for my daughter. She was born with traces of bilirubin. You know what the doctors advise? Hold the baby for 20 minutes in the morning and 20 minutes in the evening at 4 o'clock. They didn't have access to technology, number one. But the use case was so ingrained in their mind that even in an informed user scenario, it's difficult to shift behavior. So, over the last 8 years, we've done tons of stuff. So we've got about 44 products in the portfolio. But the one thing that's so interesting is our primary assumption when we started 8 years ago is so wrong. We always assume price and technology can help drive access to healthcare. It does, but in extremely small way. It's not really the barrier to adoption. The barriers to adoption are with the ecosystem. It's in the environment. It's not with the technology. So after we understood that, here's what we did. So it's very difficult to get quantified information of healthcare system. So this is the overall healthcare system that we're talking about. So if I go into a hospital and say, show me your complete records of every patient walking in, every dollar being spent into management of that patient and post-treatment management, it's very difficult to get that clarity. So we went to the US where they actually have a great audit trail of data for years. And that showed us that if I look at the cash flow of a healthcare provider, less than 10%, and in fact, Dr. Ram alluded to that this morning, nobody looks at the right-hand side of the slide that he showed. Right? A large part of the money actually goes into land acquisition, infrastructure, compensation, benefits, so on and so forth, while we keep focusing on the 10%. Whereas the focus should actually be on the other 90%, while the 10% you assume should get done anyway. This one is an interesting paradigm. So it's an icon of a doctor, prescribe. So it's a very prescriptive model that we live in. Doctors prescribe, clinicians prescribe. You go to a doctor to be prescribed something, anything, diagnosis, tests, surgery, procedure, whatnot. That is changing. Is it changing in emerging markets yet? My hypothesis is not yet. But will we leapfrog developed markets? I think the answer is yes. So if you look at the way the US and Europe are moving forward in terms of sustaining their healthcare systems, because like I told you, if you remember page 1, they are spending $5 trillion on 1.2 billion people, which means it's an underproductive system. So the only way they can drive care and patients can actually continue to subsidize the cost of care is if they take engagement and ownership for their well-being. That change needs to happen in emerging markets. And that requires advocacy, engagement, participation with the government. You can't just exclude that piece of focus saying, okay, I'm a technology company and I don't have the wherewithal to do that. Yes, you don't have it. You've got an ecosystem that you can leverage. So our fundamental hypothesis is this is an ecosystem business that needs to work with one another, rather than each business saying, I will do this and this is my side. That's something that we're trying to really push the pedal on. So that translates to my bigger hypothesis. So Rubik's ecosystem. This one, most of you would have played with Rubik's Cube at some point in your life. Every single square cube that you see in the Rubik's ecosystem actually has 43 quintillion permutations and combinations for it to be faced. That's exactly the model in healthcare. So when we go to Kenya, or when we go to Zambia, when we go to Philippines, or when we go to India, Uttar Pradesh, while the needs are similar, constrained economies, constrained healthcare ecosystem, the ecosystem that needs to come together is never a risk. It's got its own nuances. It could be barriers of language. It could be social barriers. It could be a bunch of barriers that are so nuanced to that particular entity, to that particular ecosystem that needs to be figured out. So if we truly want to accelerate care to 5.8 billion people, there is no way you can do it until every one of these things comes together. And I'm not going to spend time on this because throughout the day you're going to be hearing more and more of the fact that every single piece of this requires innovation. And every single piece requires to work with each other. It can't be silent. The last piece is it's a dramatic shift in terms of how we're beginning to view the healthcare business. We understand that to a large extent, you could say the healthcare business is social in nature. If you look at Europe, if you look at the US, they have largely subsidized healthcare systems, social security, NHS, whatnot. Flip the chart on the emerging market side, you've got a private payer market. At the end of the day, again, I'm going back to a lot of parallels that I saw in Ram's charts this morning. Email, Facebook, World Wide Web, you note the last 10 years, a bunch of innovations. The sharing economy is an innovation from that world. And we are living in a world where people are open, people are willing to share. And we need to leverage that. We need to be leveraging each other to each one see their own shared value. So it's not a philanthropic business. So G sees a shared value, partners see a shared value. But at the end of the day, the beneficiary is the nation. And that, I believe, can happen through a bunch of different means that we are experimenting with as we grow. And I think we've seen good results so far, and there's a long road ahead of us. But with that, I'll end my talk. Happy to take questions.
Yeah, thank you. That was fantastic to listen to. The GE there, this is more an observation and addressing the point which you raised. I was with a team from Stanford, and the one question which arose is, we have such brilliant minds in India, but why are we not innovating? And the single answer to that question, which came from the whole team, is, we have not innovated in creating a culture of innovation. A large proportion of our young people are afraid of innovating because they are afraid of failure. The entire ecosystem does not encourage failure. By definition, if you want to innovate, you have to be prepared to fail. But the problem is our whole system, from education to companies, including corporates, there is a fear of failure, so automatically innovation goes out, and that's why I love companies like GE and Philips who have brought their innovation centers here, because trust me, for every innovation, 99 of them fail. But the companies persist, and the ecosystem has to persist here, and that has to begin from our university and medical college levels if you want to innovate. And that I wanted to put across to you, that this is the central place where innovation has to take place in our education system, where our students are said, be creative, be think, do not afraid you're not going to be thrown out of the institute because you fail. That is the success of the university system. It all comes from the universities in the US. We don't have that. Till that, I'm sorry, but just Bangalore is not enough to innovate. You need the whole country to move into this, and that will happen only if we get rid of this culture of looking down on failure. We are still a country where people, whosoever they are, however brilliant they are mortally afraid of failing. So they will just toe the line and do the same thing. We will not get out of the box solutions. And kudos to GE and Philips and people who are at least encouraging this and bringing our people into systems in our own country. Otherwise, these same people, when they used to go out, you know what has happened and where these people are. It's an observation, food for thought.
Thank you.
How we are going to change it is not easy, but we should think about it.
Absolutely. Thank you.
Hi Vikram, thanks. It's a good presentation. It's from the time Jeff was heading the healthcare. There was a focus on low-cost country and sustainability. What's the difference now? Does Zebra machine what you assumed, it has been developed here 7 years back, I was associated with it. What is different last 6 months?
So the interesting thing is GE has been looking at localization, low-cost manufacturing. We started 25 years ago in India, so it's been a long journey. What we truly see in terms of the impact we make, and I again want to borrow a few words from what Chandrasekhar spoke about, right? It's not the number of lives you touch, but the number of lives you change. I think it's resonated with me. And that's precisely what we're going after. Yes, you can bring down the cost, and that gets you to an entitlement. But what you need here is not an entitlement. What you need here is a revolution. So going after incremental improvements is never going to get you to the real entitlement of the people who need access to care. With sustainable healthcare solutions, the big sea change, and this for us has been a learning that we've had over the course of the evolution. So for us, we made 3 changes. One, as a corporate, we have complete commercial accountability to make sure that we have focus on these markets. Because like I said, 80-20, you always tend to focus on where 20% have the propensity to pay. 80% of the people living don't. So this businesses actually focuses on the large 5.8 million people. That in itself is a big shift in terms of focus. The second thing, when you have focus, you obviously have learning. So when you have learnings, you obviously need to make a commitment. So we made a $300 million commitment to ensure we produce the right solutions, we make the right ecosystem in place, we partner with the right people to make sure we're actually driving outcomes, which is very different from what we've gone back in the past where you say localization, creating low-cost resources, talent. We're moving away from that while we continue to leverage what we have. And the last piece, I think, is sustainability. Sustainability is a large piece. It's an ocean. It's very difficult for GE to answer. But what GE can do is build an ecosystem. What GE can do is, with what we're doing, the platform we're creating, and with clinical partners we have, with partners with the governments that we have, we've experimented with it. I think everybody sees shared value. And shared value therefore becomes a big part of sustainability. I think those are 3 big things which are a sea change from what we've done in the past. Thank you. Sorry.
Just to know, since it's presentation, I'm just thinking about it, and companies like you or other equipment companies here, is it a good idea to do reverse engineering and strip the Mercedes-Benz to make it to Toyota? Would that be a faster answer, for a country like ours where we need to cut the capex, as yourself said, we spend very little on the technology capex anyway, because technology itself is very expensive. To get a Stryker OT is not going to be easy. To get a 3 Tesla MRI is not going to be easy. But is it a good idea to strip down, and use that, because then you don't need too much of innovation?
If you ask me, that would be a fastest path to the market, but it's not going to be a growth path. It is like in my mind, a temporary solution that helps you play in the market, get your feet in the door, and learn. But with that learning, you really need to look at ground up. And our story is exactly that. We've gone from Giraffe Omnibed, which is our Mercedes-Benz or Ferrari of infant care, to Lullaby Warmer. And from the Lullaby Warmer to the Lullaby Warmer Prime, which is a completely ground-up approach versus deriving something down. The other reason why I say that is, if you derive something, you're going to have constraints on how much you can derive. You can't go to the port. There's always an entitlement below which you can't do anything else. And it's designed for somebody else's use case. You come to India, the use case is very different. You go to Africa, the use case is very different. You can't expect users in Africa and in India to adopt the use case of somebody sitting in, let's say, the US or Europe. So I think from that perspective, affinitization to the solution happens when you go ground up versus top down. So you need to do both. It's a question of how much time and how much focus.
You can choose.
Absolutely.
Just one point, Vikram, I thought Ganesh Prasad from Genworks. Just one point to add to support to Vikram's answers is Genworks is a distribution innovation. We make technology and we have to take it to the last mile. We have to take it across the country. That's one reason why GE created Genworks, to take this technology, and explain the utility and enable adoption, to make sure that everyone understands the value of this in improving outcomes. So that's a big step.
I didn't want to steal your thunder, Ganesh. You're going to be speaking.
I just wanted to make sure that we tie in.
Right.
Vivek, just saying, this is popularly known as Shanghaiing technology or Guangzhouing technology, where you strip it down and then you rebuild the same thing. But if you look at the China experience, there's been no innovation coming out of China. They just strip it down, they copy it, give it to you at a lower cost, but it has not addressed some of the issues even in the Chinese ecosystem, except the cost issue. You can probably make it at a lower cost, but there's no value addition to that product coming from there. And that is where their markets are facing a problem now, that they were just producing Me Too's. And now when the time comes, show me something different. They have nothing different to show.
Let me just ask you about answer and sorry for taking us such a long time. Nice, to take a Mercedes, bring it down to Toyota, and many times the insights, the identifiers are missing. If let's say we take the case of endoscopic surgeries in India, many of our surgeons, when they finish their medicine and finish their surgeries, many of the students have actually not seen an endoscopy procedure. They end up learning it much later. Whereas if you take any advanced country, US, Europe, they would have learned through a simulator, they would have learned to do this. Now if we had a solution which could address the fact that many surgeons did not learn endoscopy MI surgery, that product would look very different from the one which assumes a basic skill level. So the design will have to start in a different place. And if we try to strip it down, it's more expensive. So in the short term, we are doing it. I gave the example of the power tool where we looked at it and said, these elements, let's bring it back. If we were to redesign one from the grassroots, it would look very different.
Thank you. Quite interesting exchange. May I request Dr. Vivek Desai to please hand over the momentum to Mr.